Hi, my name is Jhamani Ashcraft, and I will be proposing the comparison of birth complications in midwifery-led care and obstetrician-led care. So here I'm just going to explain my overall proposal. Obstetricians for years have managed labor progression by standard labor curves, and based on that, studies have found this direct link between the standard labor curve standard of care and increased cesarean rates in the United States. There is a clear difference in the standard of care between certified nurse midwives and obstetricians, as certified nurse midwives have high touch and low intervention methods of care. In terms of their management of the progression of labor. This study will thus analyze this difference in management by comparing maternal mortality and cesarean rates for women in labor under midwife-led care versus those under obstetrician-led care among nulliparous low-risk term women. It is proposed then that women in labor under midwife-led care will have reduced rates of cesarean and maternal mortality compared to those under obstetrician-led care. Here are a few keywords I'd just like to go through. So I mentioned nulliparous women is who I will be working with mostly. That is the medical term essentially for women who have never given birth, whether that it be by choice or for any other reason. Cesarean is the surgical procedure for delivering a baby, mostly through the abdomen. And certified nurse midwife is the term for someone who has exceeded the International Confederation of Midwives' essential competencies for a midwife and is also an advanced practice registered nurse. Spontaneous labor in this study will be defined as a vaginal delivery that happens on its own without requiring doctors to use tools to help pull the baby out. As explained by Hutchison and others in 2020, defining the stages of labor with a specific beginning and end has allowed clinicians to study labor trends and to create labor curves based on labor progression. This began with the observations of Emanuel Friedman in 1954 and has been studied by a number of researchers throughout the years since then. So in this study, the progression of labor will be described in terms of these three stages as defined by Emanuel Friedman. The first being consisting of two phases, latent phase and active phase, latent phase being the beginning of cervical dilation through 6 centimeters and active phase being 6 centimeters through complete dilation of 10 centimeters, going into stage 2, which is the complete dilation through the expulsion of the fetus, into stage 3, which is the delivery of the placenta or afterbirth. We are placing an emphasis on the active phase in the same manner as physicians for reasons that will be explained. Since by now I'm sure you're thinking, why do we care? What is so important about labor progression management? Well, here are a few reasons why. So labor progression management essentially ensures a successful delivery for both the mother and the fetus, and it is important for the progression of labor to be closely managed from start to delivery, as it helps to determine the possibility for potential intervention during the delivery process on behalf of the physician. And in addition to that, prolonged labor has been associated with several complications such as postpartum hemorrhaging, chorioamnionitis, and other neonatal complications. As I mentioned before, the standard labor curves that are used by clinicians were originally defined by Dr. Emanuel Friedman in 1954 in his preliminary study in which he analyzed labor progression in full-term nulliparous mothers. Based on the dilation of their cervixes and fetal descent, he then formulated a sigmoid-shaped graph of linear labor progression. As you can see to the left, it is a normal labor curve. It is this study that helps him to suggest the standard of care used by obstetricians today, in which he suggested that if the progression of labor in terms of cervical dilation is halted or decreases prematurely according to his sigmoid curve, then the obstetrician should seek to intervene. So if the slope of their, the theoretical slope of their labor curve did not somewhat match up to his, then they should seek to intervene because there could be some type of complication. So it is by these standards that the 2-hour rule came into fruition, in which it was mandated that if there are no appreciable changes in uterine contractions or cervical dilations for more than 2 hours, then intervention is necessary by the physician. That intervention, more often than not, is simply a cesarean delivery. Now, this differs from the midwifery standard of care, as midwives do not follow these exact guidelines for progression and in fact take a more philosophical perspective to care. The difference in care is evident as explained by a study conducted in 2018, in which it was found that decreases in midwife-led care presented increases in rates of operative births, i.e. cesarean deliveries. And again, it is this difference in care that has accounted for the increase in cesarean deliveries in the United States. A 2020 study done by Cohen and others expressed that if we were to redefine what is considered to be the normal progression of labor, the rate of cesareans will be reduced. With that being said, this study is modeled after the research conducted by Voon and others in 2017, comparing midwife-led care and obstetrician-led care on maternal and neonatal outcomes in Singapore. This study differs from previous studies because it will investigate further than just the potential relationship between the methods of labor care and cesarean rates in the U.S. By analyzing a potential relationship with the methods of care and maternal mortality rates in the U.S., which is not something that has been typically done in studies prior. As shown in the figure below, the collection of data will start in the beginning of November and continue until the end of the project, while the statistical analysis of the data will begin near the end of December as thesis writing starts in mid-January. And as it is a retrospective cohort study involving medical record review using the U.S. Center for Disease Control Wonder Public Health Data System, IRB approval will not be necessary for the data to be utilized. Now, getting into the specific aims of the project, I hope to compare cesarean rates for women in labor under midwife-led care versus those under obstetrician-led care among nulliparous low-risk term women, as I mentioned before. So I hypothesize that women in labor under midwife-led care will have reduced rates of cesarean, as we've seen in the previous studies, and that would be the rationale behind that. My second specific aim, which is the thing that basically makes this study different from others, is to compare maternal mortality rates for women in labor under midwife-led care versus those under obstetrician-led care, again among nulliparous low-risk term women. I thus hypothesize that women in labor under midwife-led care will have reduced rates of maternal mortality compared to those under obstetrician-led care, and this is based on the fact that those under obstetrician-led care typically have higher cesarean rates due to their high intervention methods in comparison to low intervention methods with midwife-led care. In terms of my experimental design, I will use live birth counts from the national and state summary counts from the CDC Wonder Data Bank, and I will be using data derived from birth certificates. It goes back as far as 1955, but I would only include those from about 2000 to the present of 2020. I will be able to then determine the percentage of cesarean rates and maternal mortality rates between the varying delivering methods. And the criteria that will be applied in terms of the selection of the subjects will allow the researcher to filter the data to a greater extent. For example, I will be able to select for urbanization classifications as well as different maternal and paternal characteristics to be included in the data, as seen in the photo to your right. I am then looking to filter the data for low-risk nulliparous women, which would include women who have never given birth prior and are greater than or equal to 37 weeks gestation and are experiencing spontaneous labor. As shown by the table here, this would be an example of a result from the CDC Wonder table. And the group counts obviously will be obtained by a variety of demographic characteristics, such as the delivery method, which is an expanded delivery method, which specifies whether it is vaginal, excluding previous C-sections, and whether it was a primary C-section or things of that nature. In addition to that, it is also obtained by medical attendant, which can specify between certified nurse midwives and other forms of midwife, as well as the final delivery route and delivery method, and even birthplace and maternal morbidity will be checked. The group counts will be obtained by demographic characteristics of that nature, and the counts can also be measured by the number of births and percent of total birth, as seen to the right. This study will use the data sets about mortality and cesarean rates, and the requested data can be readily summarized and analyzed through the CDC Wonder Network. The CDC Wonder Network produces tables, maps, charts, and download tab delimited text exports of the summary statistics, and the dataset will only include counts of live births occurring within the U.S. to U.S. residents. As said before, we will be following the data analysis of Voon and others from 2017 study, which approached data statistically from multiple regression standpoint, which tests for the main effects and controlling for the multiple covariates. So the multiple regression model is used to model the linear relationship between the attendant of delivery or the method of care and the response being that of cesarean and maternal mortality rates. So again, what is the significance behind the study of this maternal mortality difference between the standards of care? So essentially, we could eventually help in the development of better standards of care in the management of labor progression, especially within the United States. And this makes a large difference in terms of helping to reduce rates of cesarean and as well and the reduction in rates of maternal mortality within the United States. And to conclude, here are my references. And I'd like to give a special thank you to Dr. Warman for all her help in the development of this proposal. Thank you for listening.